I represent Insurance Information Bureau of India. This is a part of the insurance regulator. And what we do is we collect health information data from all the health insurers working in India. So there are around 32 health insurance companies today. So we do get real-time data from all of those health insurers. And in return, we do have certain products which help them expand their business better, underwrite the risk much better, identify fraud, waste, and abuse, and also build some innovative products and solutions. So the way I represent is more from a health financing in the private sector perspective. But again, the vision is same. Like we have Viksit Bharat vision, one subset of that is Insurance for All 2047 vision, which is driven by IRDA. So I think we are all working towards the same final objective. I think one of the core questions, if you look at the health insurance companies today and the way they interact with the hospitals, we call them as providers of services, there are a lot of gaps existing across. One is the major challenge, if you see, and you would have seen in a lot of media, is about claims getting rejected or hospitals stopping cashless facility, sometimes insurance companies stopping cashless facility. All this is happening because of we do not have very efficient contracting mechanism based on evidence today. The contracting happens either majorly on the volumes, businesses, and there are specific interests with both the parties kind of stuff. So one of the things we are trying to do is create a very authentic, secured, and complete data. That's the first step we want to do, which will help in addressing some of these mega problems. So premiums is outcome of all of this. If there is not so great contracting, you see very high claims experience, and high claims experience, because these are all business bodies, ultimately it leads to higher premiums on a long-term basis. And this, I'm sure, is a fundamental mechanism even in state health schemes, which happens. So in a way, what we want to cut the circle here is find the right sweet spot using data. And in data, we are saying specific coded data at a very granular level. So ICD-10 diagnosis codes, ICD-10 PCS codes are becoming mandatory now. It is still not 100% mandated, but at least the first step of including that as a mandated data field to be captured by every ecosystem in this data flow is being made. Now, of course, there are further challenges to that. Who will be coding? What is his expertise? What is his motivation to code? Today, hospitals do not code because there's not much of motivation for them to do that. How do we build that motivation? Can we build an incentive to the hospital for better data management, submission, and outcome measurements? That is something which we are building it as a framework. And I guess that's one of the things which is very important towards deciding the premiums kind of thing. Second, to specifically see what happens in private is the portfolio is evaluated every 3 years. Earlier, it was evaluated every year. So premiums were going up every year, which was a very, very serious thing. Somewhere regulator put a stop to it. So you cannot do this every year. So now it's once in 3 years. And once in 3 years, the portfolio is evaluated by the respective insurers to see if we need to increase the premiums. But I think the core fundamental here is not about the frequency of evaluation. It is more about how are we managing the increased cost? Is it more than the inflation? Is it less than the inflation? And if it is more than inflation, there's definitely some outlier, some kind of waste and abuse which is kicking in here. So those areas is what we are doing. So we're still in a very initial stage of collaborating with the providers system here. But again, one more thing, and I was discussing with Madam, was we need to have central coordination between authority, insurers, and hospitals, all three coming together for a common cause.